Someone wants to know what's wrong with them, what can you do about it, what can I do about it, and how long will it take? So I think if you think as you're working through with someone, give them a really clear idea of what you think is going on in the picture as best you can, including any grey areas. That's okay. Humans are messy. That's fine. I'm really honest about that. I'm really honest if I want different opinions. I think that's good. It actually, we don't have all the answers.
Yeah.
What can you do? What can you do about it? Gives me an opportunity to say, okay, Nathan, we used to think that tendons were inflamed. We used to call it tendonitis. I'm going to use this as a teaching moment to explain to you what tendinopathy is, explain why exercise is important.
Welcome to the Mind Body Literacy podcast and videocast. I'm your host, Nathan Schechter. A lot of the best sharing and learning happens in conversations, often ones that are informal and private. But what if you could be a fly on the wall and listen in? The Mind Body Literacy VP cast highlights different people with different perspectives. It's particularly aimed at sharing insights between professional silos of knowledge that work with the mind and the body. So, for example, massage therapists can hear how psychoanalysts think, and neurologists can hear how their ideas might be used by dancers or yogis. Because the mind and the body are too complex for any one person or group of people to understand it alone.
The information and content provided by Mind Body Literacy and in the Mind Body Literacy podcast and videocast is general information, and it's intended for educational purposes only. Individual situations vary, and this content is not intended as, nor should it be used as, a substitute for professional, medical, or psychological advice, diagnosis, or treatment. No guarantee or warranties are given with respect to the accuracy, applicability, fitness, or completeness of the content.
One of the underlying ideas of this podcast is how learning and new information, they change. How we see things, what we understand, and what we think we know today, well, it might change tomorrow. Whether you're a coach, professional elite, a teacher, a clinician, a performing artist, or just somebody who's trying to figure out about your own body.
And that's why I'm excited to share today's episode, a look at how physical therapy has quietly evolved over the past few decades. Science, movement arts, and clinical practice are constantly evolving. And my next guest's work is a perfect example. When I first came across her research in 2015, I was thinking mostly about movement, muscle, and fascia. But her work opened my eyes to the fact that tendons are a whole different story. How they respond to load, how pain fits into that picture, and that there are clear evidence-based steps to help tendons recover. Even when we recorded this episode last year, I was still learning new things, like how the speed of exercise changes whether a tendon actually receives load. When she returned from the 2024 Summer Olympics in Paris, I had the chance to sit down with Dr. Ebonie Rio. Ebonie is a sport and exercise medicine physiotherapist and one of the leading researchers in tendon health and pain science. She's a passionate teacher and presents at national and international conferences, guest lectures at universities on tendon health, foot and ankle rehab, and pain science, and supervises master's and PhD students. She's worked with everyone from Olympic athletes to everyday people who just want to move without pain. Her career has taken her across the globe: the Paris Olympics, Vancouver Winter Games, Singapore Youth Olympics, London Paralympics, and 2 Commonwealth Games. Beyond sport, she spent 18 months as physiotherapist for Disney's The Lion King during its Melbourne and Shanghai tours, and she serves on the scientific advisory committee for Little Big Steps, a charity helping children stay active through illness and recovery. Her approach also reflects something I value deeply: honesty about what we do and don't know, and helping people understand their bodies and empowering them to be proactive. Ebonie's work sits at the intersection of science, movement, and care, driven by one mission: to help people move better, recover smarter, and live healthier. I'm really glad to share this conversation with you. Here's Dr. Ebonie Rio. So welcome, everybody. It is my pleasure today to welcome Dr. Ebonie Rio. And Ebonie, as we're recording this, it's the summer of 2024, and you have just come back, as I understand, from the Olympics in Paris this summer. And I wanted to ask you about that because you've done really super interesting things. Like, you've worked with athletes, you've worked with artists, you've worked with ballet companies, you've worked with football. And I wanted to ask you if that's American or European or Australian, but you've seen a lot of athletes and artists. And I'm just curious what kind of led you to working in those places, and also what you learned from it, like what you observed, what you experienced. I'm really interested to hear about that.
Well, first of all, thank you for having me. I'm really excited to talk to you, and that's a great first question. I think across all of those different groups, whether it's dancers or, the different types of athletes, they share that common drive and that passion and that motivation. And they're also driven to be better at their craft. And that's really special to be part of. So even though there's so much variety in the groups that you talked about, they have so much commonality. And I think it's that that drive to push their physical and mental capacity to the edge and beyond is so inspiring. And that's probably the part that I love, contributing to or trying to be part of.
Yeah, no, that is super, super inspiring, and also very palpable to be around. I remember that from I'd worked in big organizations, and I went to boxing gyms, and like some of the most motivated people you would ever see, because nobody cared if you practiced, nobody cared if you showed, like either you did it or you didn't. And so people so badly wanted to learn, people would push themselves. And I was like, this is the highest level of motivation sometimes that you can see is with athletes or with performers. It really is something you can observe and feel. So I totally understand that. You've also done a lot of your work with understanding tendon dysfunction. And I know that we'll have some folks listening who, this may not be their field, or they may not be that heavily into it. So I just wanted to start off with a few definitions and the basics, because, my mother back in the day didn't know the difference between a tendon and a ligament. So could you start us off by just saying, what is a tendon, and, what does it do, and that?
Yeah, absolutely. And it is really great to define the terms, because there are so many words and people use them, often interchangeably, especially in the media and, when we're Googling. So I think terminology is really important. So a tendon attaches our muscles to the bone, but it's not just a passive structure that kind of just, that's all it does. It actually, in our lower limb, really acts like a spring. So it makes our movement more efficient, but it's also what makes our athletes and our dancers really good. So they have really good springs, they have really good tendons. So in our lower limb, our tendons mainly act as a spring to store and release energy. So whenever you're, running and jumping, you're really using that Achilles tendon. But we need to use that tendon throughout our whole life. If you step off a curb or walk downstairs, you actually store and release a little bit of energy in your Achilles. So our tendons are so important throughout our whole life. So not just for our high level athletes and dancers, but, for all of us, they're really important. And that's why we can see, injuries in a really broad spectrum of people. Now, when the tendon is injured or we have pain or it's dysfunctional, we call that tendinopathy. And we specifically use that term because it's not an inflammatory condition. So we don't want to use words like tendinitis. Because if we say to someone that, you have tendinitis, one, it's inaccurate, but two, it'll conjure up really passive approaches to their treatment. So they'll think they need to rest, they think they'll need ice, they think they'll need anti-inflammatory medication, and actually none of those are effective. So the best evidence for managing tendon pain is exercise. And so tendinopathy is a really important term to help people navigate and understand the underlying kind of, function of what's going on. Now, a ligament goes from bone to bone. So you've got ligaments in your ankles, and you've got ligaments in your knees. All of your joints have ligaments and capsules, and they're quite passive. So they're really important in terms of stability and structure. But they're not as cool as tendons, because tendons actually help us function at a really high level. But I'm pretty biased, Nathan.
Yes, the tendons are the cool kids in school. And
Correct.
this is something that I wanted to ask you. I think it's changed over even like the course of our lifetime, right? Like it used to be, I remember, I think when I was younger, like if the elbow was bothering you, you had the tennis elbow or the ankle or the knee, you called it tendonitis, right? You say, oh, it's tendonitis. And I think to what your point was, you just think in your mind, like, well, if I burn myself on the stove, they tell me to put my hand under cold water or put ice on it. So if this is inflamed and hurting me, I guess I should put ice on it and maybe I should rest. Like that seems to be the smart thing that I would do just naturally. And that has really shifted. And I think one of the things that you're pointing out here is that there's a difference between an itis, an osis, and an opathy, that these words. And so could you tell us a little bit more about like, what does somebody mean when they're a clinician and they say, well, you have tendinosis, or they say, oh, this is tendinopathy, or somebody says, well, look, I have this picture and it looks thicker and, I'm worried about that. Can you tell us a little bit about that?
There's actually so many great questions in there. So the first thing I'll say is that tendinopathy is the term that we should be using. So tendinopathy is the term that's been agreed in an international consensus project that we ran. We included, clinician experts, research experts, we included patients. So the term tendinopathy is the one that we should use. We shouldn't use tendonitis at all. It's actually not a clinical condition. You're exactly right. It's what we used to call it. And that was because that reflected our understanding of it. And it's okay that our understanding changes over time, but we need to make sure that our language also changes over time so that our patients don't have those instinctual kind of expectations about treatment. Otherwise, there'll be a real mismatch between what you're saying and what they think needs to be done. And, just to highlight how important words are, there's a fantastic systematic review, and they looked at manipulating terms and the impact on people's understanding of what they needed to do. So if you tell people that they have a fracture, 56% of people think that they need a plaster cast. If you report the same injury as a crack in the bone, 13% of people think they need a plaster cast. So it's the same injury, but I've changed the words and people's underlying understanding of what they need to do is different. So tendinopathy is the same. If we're not being really careful with our words and we're allowing people to just sort of say tendonitis, and then I'm giving you an exercise program, deep down you're thinking, but doesn't she know my tendon's inflamed? So we have to take that as an education opportunity to say to people, yeah, we used to think that that the fluid and the swelling that you see on imaging, we used to think that was inflammation. We now know that it's water, because some of the pathology, some of the changes are that the tendon actually draws in water. So the tendon gets thicker, but it's not inflammatory in the way that when you burn yourself or you sprain an ankle, you sprain a ligament, or you pull a muscle. It's a very different process. So tendinopathy is the term that should be used. Tendinosis refers specifically to the pathology. So what that means is if you have tendon under a microscope, you're allowed to use tendinosis, but otherwise it's not a helpful clinical term. It's, even the terms that are used on imaging reports aren't that consistent. So that can be really tricky for people. But there's one more thing that you said that I just want to take the opportunity to teach people. We used to worry about a thickened tendon being bad. We actually know that that's highly adapted. So Dr. Sean Docking did some research in the Achilles and the patella and showed that if you have changes in your tendon, you have as much normal tendon or more than someone with a completely normal tendon. So the increase in thickness is an adaptation. It allows me to have enough load-bearing tissue to do my rehab program and to do really well. So an increase in AP diameter or anterior posterior diameter, or an increase in thickness, we should be celebrating that, not fearing it.
Yeah. So it sounds like, just as with many things, people are relating to sort of what they're experiencing. And that first sense is, something's wrong. Or even if something's not wrong, it's like when people try to use nutrition, am I hungry? Or what's this sensation that people are trying to put words to experiences. And the way that they do that can determine a lot of things. It can determine, well, if I say I'm hungry, I'm going to eat. If I say I'm just stressed, maybe I don't eat, And so if I say this is a tendinitis, then I conjure up an explanation, which is, inflammation, therefore ice, therefore whatever. That's taking me down the wrong road. And I've kind of made a connection between my emotional state and my cognitive decision-making with a word that's kind of heading me towards a treatment decision that may not be in my best interests because what we've learned has changed. Whereas if I say tendinopathy, now I have something that suggests to me, hey, first of all, don't worry so much about changes in thickness or seeing water or the state of the collagen, or the collagen's going from 3 to 1 or 1 to 3. Like, don't worry about that stuff. That's not so much what's important. If you stick to what we've kind of defined as you just described for us, and you use this term, that's going to put you on a good middle path where we can start to address the issue and actually bring back function, actually address pain. And this is so using that word is more helpful for many of those reasons. Am I hearing you right?
You've nailed it. Perfect.
Okay. Great. All right. And so I also wanted to ask you then a little bit more specifically about isometrics, because I know that was some of your work. That's also how I first became aware of you. I think you had written a paper in 2014, and then I'd seen something, I think in Switzerland, you had presented in 2016. And this was on patellar tendinopathy. And you were talking about how isometrics are good and helpful and also address pain to some extent. And that also, when I read one of your papers, it was very interesting because it seems obvious in some ways, and not only obvious, but intuitive for people. But I sort of thought, you're saying exercise can produce pain relief, and that can be done, properly and improperly. But, one of the first things I ever saw when I was teaching yoga was people would be titrated out of their PT, and they would show up, to try to use a group fitness class as physical therapy. And you'd have to say maybe that's not the best. Maybe we need to redirect you a little over here. But it was the right impulse, right? Like it was the right impulse of, I want to use movement in some way to help myself. And I want to be proactive about that. Like right impulse, maybe needing to go to a different place. And so you had done this study, I think, which was about an 18-month study. And just if our terms are going to be defined again, so help me if I'm here, but so concentric, eccentric, right? Isotonic for people who don't know at home. And then I take my arm and I squeeze really, really, really hard. No change here. You can feel, the squeezing. So now we have our isometric, right? And so you did this study, isotonic versus isometric. You controlled for a lot of the same things. Time under tension, which is basically how long you're having the muscle under tension, the rate of perceived exertion, the rest periods, and a lot of other things. But can you tell us a little bit about that and kind of what protocol you came up with, and a little bit about how you got into that and what you observed?
Yeah, sure. So I think a good place to start is to understand what a tendon does. So we talked about a tendon storing and releasing energy. So for it to be high tendon load or high tensile load, it's got to be fast. Tendons are about rate of loading. So the converse of that, Nathan, is that anything slow or static is easy for a tendon. So that's really how the research started, that basic sort of first principles. So Craig Burdham and Jill Cook had been, using it clinically, and, I was involved with them. And essentially the reason I designed the study is I just thought we're warming up the tendon. I honestly didn't think it would matter what we did. And so to answer the question as to whether or not the load type was important, that's why I tried to control all the other variables. So same time under tension, all of the things that you described. And essentially the first study that we did was a laboratory-based proof of concept study. So very tightly controlled, nothing like the real world, with a Biodex. And for people that aren't familiar with a Biodex, it's an isokinetic dynamometer, but what it is it's completely fixed. So if you're doing an isometric, you can't move it. So it's a completely static, immovable load. But what you can also do is provide feedback for people so that they're producing the force that you want. So the first study that we did, we compared the two types, and we found that people had pain relief from both, but a greater immediate pain relief from the isometrics, and that was associated with a change in their inhibition. So inhibition is kind of like the brake in your brain. So when you do a movement, it's a balance between your excitability or your accelerator and your inhibition or your brake. And what the isometrics were associated with was a lifting of the brake. So people were actually stronger after doing it. They could actually access more of their kind of motor neuron pool. So even though they'd done, 5 lots of 45 seconds at 70%, it's quite hard. They're actually 18% stronger, which meant that clinically it was quite a safe thing to do before, training and playing, which is really important to know if we're going to try and use it in the real world. We then took that study into the real world and did it as a randomized controlled trial in season. And we used a leg extension. And what we found with a leg extension machine that you have to kind of hold at a certain angle was that we didn't have as profound immediate impact. So people could, it's quite a different isometric. Does that make sense? Mm-hmm. So we found that both isometrics and isotonics helped people over 4 weeks. Again, people had a more profound immediate effect with isometrics, but the key clinical message is that they're both really safe in season. And that's important because the research that had been completed before that for in-season management showed that if you add eccentrics in, people did worse. So clinically, if we're managing athletes at the Olympic Games or we're managing, dancers during a performance season, we didn't have great research supporting exercise that was safe and effective. And you're exactly right. Coupled with our terminology, we want people to understand that exercise is actually our long-term strategy. So introducing it really early and when it's associated with, pain relief or analgesia is quite motivating as well. It's also something that people can do themselves, which I think builds self-efficacy, and it's drug-free. And so, obviously, as a physio, I'm very biased towards exercise, unashamedly, but I think, it provides us with a way in. We have someone with tendinopathy. We don't need to wait. We can immediately start with safe, slow or static load and then progress them back into, whatever they want to do.
Yeah. So it sounds like you're saying you took folks, you hook them up to a machine. This machine has the ability to actually measure the force that somebody's putting out. So you can make sure it's commensurate for each participant. They then go through putting out isometric force. You measure it at a certain level, and that was the first stage of this. And that you then see, hey, this has a helpful effect in terms of reducing pain. And a lot of folks don't know that athletes work, have kind of an off-season training, and an on-season training. Obviously, when they're doing the full schedule of the ballet or they're, doing the full games and competitions, the trainers, the physios, the people who work with them have to adapt around the loads and the conditions that are changing. For most people never see this in their day-to-day lives, so they don't even know what those schedules feel like. But there's often different demands at different times. And so what somebody like yourself has to look at is, okay, well, I might be able to do this with somebody on an off season, but on season, they got to get right back on the field or they got to get right back on the dance floor. So if I have them in the physio, clinic and they're contracting or they're lifting or they're loading, if I do X with them, will they be able to perform at the same level and compete at a very high level? Or am I making them worse? And their coach is going to turn around and go, what the heck are you doing? And so you then look at this, you test with the leg extension, you go, hey, this is not only awesome just in general for folks, but when you're working with these athletes and these high performers who have these different demands at different times, we can actually work with them at the time of maximum load, maximum demand when they have to perform at their best. And guess what? If we use isometrics, not only do we reduce pain, but they still perform at as high a level. And guess what? They actually can even perform and put out a little bit more power because this funky thing that happens inside of us where our brain has these wires which go down our spinal cord and there's this little interneuron down there. And if you wrap it around with another little neuron and it acts like a dampener, we can actually get that to relax a little bit and get a little more power output. So it's good for high performance. It's good for pain relief. We can give it to them. They can do it quick. And so this looks like a really useful intervention. And that was sort of the path that you saw. And then you can also say like, hey, and even if you're just at home and you're not competing at the Olympics or dancing Giselle, like you can still use this because It's helpful, it's self-efficacious, you don't need a drug for it, it's cheap, you can learn this stuff. Am I hearing you right?
You've nailed it. Perfect summary.
And let me ask you something else, because I know you say often when you're talking about tendons that like fast compressive force, and just again to define our terms. So, a really good thing that I got in training was they would teach you the difference between compression where bone hits bone, right? So like if you're a yoga teacher, don't try to adjust somebody if two bones have come together, because bones don't move in the same way tissue moves. But then if it's just tight tissue has a little bit of give. So these places, and you use the example often of dorsiflexion where your foot, is like this rather than plantar flexion where it's like that. But if you have a compression where some joint is compressed bone to bone, and then you move quickly, so you're running and you're sprinting and you turn on the field, that tendons don't like that. They don't like fast movement. Okay, just to correct myself, what you said before was tendons need loading, and they need a lot of loading, and they need to experience that. But an injured tendon in somebody who is recovering and has had acute injury, that might not be the place that you want to start putting them into compression and quick, fast speed. Am I saying that at all right? Please correct me if I got anything wrong or misled anybody there.
No, spot on. So it's just where you don't want to start. So it might be where you need to end up. If that's what our tendons are designed to do. But you're right. If you've got a grumpy tendon, what you would take away, Nathan, is the fast stuff, and you take away the compression. So compression for a tendon is where the tendon is squashed against a bone. So you're right, for the Achilles, as it comes down and you go into dorsiflexion, or you put your knee forward of your ankle, your tendon is compressed against the back of your heel. That's why if people have insertional Achilles problems, they don't like being in bare feet, because they get into compression sooner. They prefer to be in a shoe with a heel. They don't like doing half raises off a step. They can actually be quite provoked with yoga, because a lot of downward dog is in a lot of dorsiflex positions. If you've got hamstring tendinopathy, bending forward can be a problem, sitting can be a problem. So that compression is something we would take out early. But what we want to do is work out what people want to get back to and help expose their tendon to some really gradual adaptation and progression to get them back to the faster work and to get them back to the compression, because it's, compressing our tendons is part of life. And so you're spot on. It's a good strategy to take out early and then work out how we help people get back into it. So it isn't, you can never stretch your Achilles ever again, but maybe in the short term, that's going to help you to avoid.
Right. I think that's something also that people struggle sometimes to understand, that, what you're saying and what I'm hearing is, look, tendons are meant to bounce and jump and do hopscotch and, run and twist and do basketball and go up for the big, layup and come crashing back down. Like, we're built to do that. We're not made out of sugar. But if you have acute injury or trauma, now you're in a slightly different category for a moment. And again, of course, tendons are different and are treated in different ways. The patellar tendon is different than the Achilles tendon. We don't treat everything the same, but just talking in generalities, if we've hurt or tore the Achilles, like, we don't then say, hey, go do a lot of jumping and plyometrics, right after the day after you tore it. That's probably not great advice. So we set that aside, and then we have a protocol. Often people don't even understand protocols just for building muscle, let alone protocols for physio. And they don't understand the difference between training and physio, right? Which I try to tell people, like, injured tissue, physio, healthy tissue, trainer, but there are steps to the process. And so you say, okay, look, if it's a physio issue and it's got to go through the stages, and let's say it's the Achilles, we're going to take away the strain on it in the compression where the tendon is getting pushed against the bone. We're going to give you like a high shoe to support you. We're going to try to let things calm down a little bit. Yes, we do want to get you back to jumping and twisting, and we are going to reintroduce that. But before we do that, we got to do some other steps in the recipe. And some of those steps, as I've heard you explain, have to do with creating enough strength. And you've even said, like, so I want the person to be able to do so many split squats or whatever is real elevated foot squats or one-legged work, and I want people to be able to do this much, calf raises, bent or straight-legged. And so I have this step I got to get people through. You show me that you're okay, you're performing, your pain isn't going through the roof, and then we can talk about moving you on to the next step. Am I hearing that right?
Yeah, absolutely. And the way we want to teach people and empower people to go through those steps is to give them really clear goals as to what you'd like them to be able to do in that strength phase. And what we do is we teach people to listen to their tendon 24 hours after the load. So your tendon will speak to you, often not at the time. So what I mean by that is tendons are a bit tricky. They can warm up. So for some people, if they're very sore at the start of an exercise, they might pull out and do underload, do too little. Some people will warm up and do far too much. So what we don't want people to do is base their rehabilitation or their progression on how they feel in the moment, because it's misleading. What we want to do is say, okay, we're going to get you to listen to your tendon tomorrow, and tomorrow morning your Achilles, your morning stiffness will tell us if it's the same or better than the day before. Your tendon was happy with what you did. It may not be zero, but that's okay. If your pain is low and stable and similar to yesterday or better, that's a happy tendon. If your pain has spiked, then whatever we did the day before is what we've got to modify going forward next time, remembering that we actually don't need to rest. So if I flare you a little bit, I'm still going to get you to do your slow calf raises, because that's very safe for a tendon. It's not fast and it's out of compression. So anything slow or static is safe for the tendon. So you keep doing your calf raises. And then the next time I get you to do something that's a bit faster, I'd modify it in some way, do a few fewer reps, and then see how you are the day after.
I want to ask you about that, because I think it's another thing people don't really understand. You said about slow. Look, it's slow, it's controlled, we're building strength, I'm feeling good here, working with you in this way. I don't think people really understand what speed does, how speed increases force. And you even have had some pictures, just simple charts in some of your presentations showing like the different level of force that can be there, in different movements, that when you start to run, when you start to jump, that the force goes up, exponentially. And like, I don't even know how good our data is on this. Maybe you can tell me, but I know that we are still trying to learn how to measure inside of joints, which is very difficult for ethical reasons and a lot of other things. And that, like, if you look back to like articles in the 90s, like they'll say things like, yeah, we had a study in the 1940s and it told us that it's like 3 times your body weight, with running, and up to 16 times your body weight with jumping, and, 3 to 5 times your body weight, with compressive forces when you're standing. And they'll give you these numbers. But I don't think that people really understand the difference, that when you start to run or when you jump and come up down, there is force. And even because one of the things that I see a lot and have seen a lot, people will exercise in a way that is very poor with form, and they'll do it quickly. And you want to say to people, the idea of exercising at speed with poor form, having force going at an angle into a joint, that's just not a great idea. And then you say that, people say, well, you're just a purist. And you're like, no, like there's a real thing happening there, and you're using a machine. And would you take your car and like whack it on the side with a wrench? Like there is. And I don't even think people sometimes understand that when you go through a car, if you're in a car accident, God forbid, but it's force that's hurting you. And it's not, even if you were immune to glass and metal and somehow you had a body that wasn't hurt by that, it's the force. So can you talk a little bit about how speed interjects force, and why when you jump or you run, suddenly it's not the same as when you're just walking, that something has actually changed that you can't see? Can you say a little bit about that? Because you said, well, I like it because it's slow and they're building strength and it's controlled. Can you talk about that a bit for people?
Absolutely. So if everyone at home downloads a metronome, just download a free metronome onto your phone, and then you can re-listen back to this recording and you can try this for yourself. So if you set your metronome pace to anything below 120 beats per minute, the main tissue that you're loading, Nathan, is muscle. Now, you're also loading bone because your muscle pulls on the bone, but that's a good thing. The muscle pulling on the bone conditions the bone for when we do walk and run. It actually keeps our bones really healthy and really safe.
You're talking if somebody's walking, when you say 120 beats, you mean walking to the metronome? Is that what you're talking about?
Anything, even a calf raise.
Okay.
Any
movement over 120 versus under 120. Okay.
Spot on. So under 120, even if you're doing a pulse or a calf raise, whatever exercise you're doing, you're mainly loading your muscle tissue. The reason why the muscle pulls on the bone is a good thing is then when you do run, your bones are conditioned to take that load, and that's good. That helps protect us from bone stress injury. So when we get a bone stress injury, it's actually not just about impact loading, it's about how hard the muscle's pulling on the bone. So strength training is really, really important for bone health. Okay, if you're loading between 120 beats per minute and 150, you're starting to load some of the more connective tissue elements. So, the scaffolding and the fascia that your muscle kind of connects into. And we need to load that tissue as well. That's really important. When you load above 150 beats per minute, for example, if I get you to hop, your natural hopping cadence is about 2.2 hertz. It's about 150 beats per minute. You're loading tendon. So what happens as you increase the speed of movement is your muscle can't contract quick enough. So if Usain Bolt runs 100 meters, his gastroc is basically isometric, and it's his Achilles tendon that is acting like a spring. If he had to contract his muscle to run 100 meters, it'd take him about, 6 minutes. I made that up, but he'd be very slow. So as you get faster, the best tissue we have to transmit the load quickly to the bone to affect our joint movement and to make our movement more efficient and faster is tendon. So that's how we load our tissues differently throughout rate of loading. So when we're talking about our slow movement, I'm talking about, for example, a single leg calf raise where you might go 1 second up, 1 second down, 60 beats per minute, slow. Below
And
120.
that's loading muscle, not
That's
tendon.
loading muscle. I'm not loading tendon. And that's why your calf raise exercises and your gym-based exercises don't put any high load through your tendon because they're too slow. But then we need to press you back into those faster things. And the way I might do that is I might get you walking up and down stairs, and I might increase the pace on the metronome so that you start doing it faster and faster and faster until you start jogging and loading your tendon. And that's how I might progress you through a rehabilitation.
So if I took a barbell and I put it on a squat rack and I locked it in place and I pushed up as hard as I can, I'm only going to ever affect, no matter how hard I go, it's just muscle. I'll never activate tendon.
Yep.
Okay. Interesting. So you start off by strengthening the muscles, making that the first order of priority because they need to be strong enough before you can go back to rehabilitating the tendon. Is that what I'm hearing you say?
Yeah, so predominantly the mainstay of strength is to affect the muscle. So if you've got a really strong, competent muscle, it gives your tendon something to pull on. Whereas if your muscle isn't good enough, it's gonna give out, and you won't even be able to use your tendon effectively.
And say somebody's made it, they graduated. You say, okay, good enough. You're doing your stuff. Your calf raises look good, and you're doing your split squats, and I'm happy with that. What's the next step that you would then, take somebody into?
So just say someone wanted to get back to running, after they've got, good calf strength and endurance, what I might do is take them through progressive stairs. So if I increase that rate of loading on the stairs, so if I go up to 130, 150, by the time I'm getting up to 150 and I'm jogging, I'm starting to load my tendon. And then what I can do is give you, some stair running, listen to the tendon the next day and say, yeah, it was happy with what we did. Great. The next time we do that session, I'm going to add some time or I'm going to add some speed, and I'll just progress that rate of loading back to whatever you want to do. If you want to run 100 meters or if you want to run, 150 kilometers a week, I just push your rehab to whatever you wanted to be able to do.
So you have your 24-hour test. You look if pain over time is going down or staying around the same but not getting worse. If so, You change a variable and you say, let's go more distance, let's go faster, something that will increase the load on the tendon progressively, as if, the same you would do for muscle, but, in this case for tendon. Is that pretty much the game there?
Perfect. Yep. Right. That's pretty much the game.
Before I ask you another question, anything else you wanted to say about anything we've talked about so far? Anything I missed or forgot to ask you? Or
no, I don't think so. I think that's pretty clear. Yeah.
So I wanted to ask you something a little bit different because I know that you also have an interest in plasticity and the mind and the brain. And certainly that comes up a lot around pain and stuff like that. And so I had a few questions on that. One I just wanted to ask was, do you think that we can control where load goes by directing it with our mind? That when we're actually involved in an exercise, that we can use our mind to say, you know what, I'm going to target the tendon, or you know what, I'm going to target the muscle, or I'm going to, somehow use my mind, because when you're, even if you're doing a leg press, or even you have a lot of decisions about where to put your feet, about how hard to press, what part of your foot are you pressing with, where are your knees, are you engaging subtly, or, and of course this can be different for different people. Some people can't feel their hamstrings. Some people are, acrobats and dancers. But, for people with good body sense, they have a high degree of control. And I know that, one of the things about like ground reaction force is, we're different than a box, right? So you put a box on the table, it has ground reaction force, but it just sits there. How we hit the ground, the angle, how our muscles respond to the ground to get that force back changes things. So I'm thinking, okay, well, if we're squatting or we're pushing or whatever, can we use our mind to purposefully shift things around? What's your thought on that? And we're getting out of, I just say, we're kind of, that's why I asked you before, kind of moving from firm territory to less firm territory. But because I deal with the art and the science and, folks on the creative and artistic side, as well as the scientific side, I like to visit both territories, because one of the things that I talk with people about is, hey, information is meant for you to ask questions. It's meant for you to integrate. It's meant for you to explore and say, I wonder if this could work. Hey, what about that? Which we don't necessarily have answers for. I wouldn't necessarily do in a clinical setting, but in a more creative or sporting or artistic setting, we certainly would do. So I wanted to ask you some of those types of questions as well.
I think we can. And I think everyone listening to this would have experience of that, where you can manipulate in real time either someone's cueing you or what you're thinking about or what you're visualizing. And I think I've learned a lot by working with dancers, because I think they have this unbelievable ability to take on so much information and so many cues about how they're moving and make subtle differences, by what they're thinking or what muscles they feel they're engaging. And, a movement to you or I might look the same, but to a trained, artistic ballet staff, they'll pick out the most finite detail. So that was a very long-winded way of saying, yes, I think we can consciously manipulate how we create a movement. And I think those degrees of freedom and the way we do things are fantastic. And I'll play around with someone's foot position or cueing on a leg press, for example, if they've got patellofemoral joint pain. If you get them to, push more through their heel and kind of lift their toes off, you can reduce some of the, the pain they feel through the front of the knee. So you can definitely, alter things for movement quality, for pain relief, for lots of different things, even just awareness, as you say, for people to move their bodies and to feel their bodies in a different way.
Yeah. And from this sort of perspective that we're looking at things from in this view, do you think we could say in some ways that people learn and unlearn pain? That, you've done a lot of work with tendon and brain change and how tendon pain can disrupt, sort of that balance between, excitation and inhibition, when the nerves are sending the messages and they have a little breaker circuit, for a very easy term, but an interneuron, right? So the interneuron can make some decisions about what gets through to grand central and what doesn't, right? And then you have this thing which you've done, which is maybe you could say a little bit about tendon neuroplastic training, right? And so the coordination of movement with tempo, right? We use tempo in weightlifting, right? But also you're using tempo in a different way. So now we're using hearing. So there is a learning process that's going on, right? And I'm just curious about your thoughts about that.
Yeah, so I was lucky enough to have Professor Lorimer Moseley as one of my PhD supervisors. And, he talks a bit about, or a lot about, pain having like a neurotag. So what that means is when a certain combination of neurons in your brain light up at the same time, you have a neurotag for knee pain, for Achilles pain. You have a neurotag for smelling fresh bread. So what that means is you get information from your body. So in the case of fresh bread, you've got what you can see visually, you've got your nose. But what happens is that sensory information arrives at your brain, and your brain has to make sense of it. And so it says, okay, have we been here before? What information can I draw on in my memory? What's my visual information? What's my, what's all the sensation I have? But have I seen this before? Was it safe? Was it dangerous? And in the case of fresh bread, your brain goes, oh yeah, that's fresh bread. So your nose doesn't know it's fresh bread. It's your brain that tells you that it's fresh bread. Pain's the same. You've got nociception and information from your body, about your not just your nociception, but your joint position sense, your muscle tension. You've got all that sensory information going up via your spinal cord. As you say, there's some modulation at the spinal cord as to what gets through to grand central. Up at grand central, your brain goes, have I seen this before? Oh yeah, that's my Achilles pain. So can you change that? Yeah, definitely. Can you, learn and unlearn pain? You can. Plasticity and adaptation and maladaptation are, one of the incredible things about us as humans. So yeah, absolutely.
Yeah, and that process of adaptation, that is something, that is a very curious part of all the different, physical pursuits. The thing I wanted to circle back to was you had said earlier when we talked about definitions and how important they are and and I think, because we can get lost sometimes in the science of it. And for people's experience, it's often just I'm hurt or I'm worried or, it's much more simple. And
Yes.
And also it's an interpretation. It's also, I think that's where the anxiety comes from, which is what's wrong? I don't know. And I can't see it, right? Like I cut myself, I go, okay, I cut myself, I see it, but these internal things I can't see. And that can affect us, right? How we explain what's happening can affect our decision making. And I wanted to just use an example that I had come across once, where somebody had actually come in and was backing off some on exercise just because they said, well, it hurts a little, or I have this, and then they came back another time and fine, everything's good and raring to go. I'm like, well, what changed? It was an allergy to food, but because it produced sensation in the joint, they interpreted the sensation as if it were injury. It wasn't injury. Yeah. It was a reaction, but that's the experience for people, which is I have a feeling and I don't know, especially to see this in kids, right? Like I have a stomach ache and it makes me super worried. It's just a stomach ache, but I don't know anything about this. And so now I'm worried because I have this inner sensation. I'm trying to put a label on it. I don't understand it. And that can, I think, not only drive the kinds of things that we're talking about with words, but also does that not play a role in treatment adherence too? Like if I feel like my ankle is injured, and even though the person tells me it's tendinopathy and I should load it, I might be kind of hesitant to do that because you know what? As much as you tell me that, it hurts. So what are your thoughts around that?
I think you've brought up one of the most important points about how we frame and allocate time and our conscious decision-making about structuring our time with our patient. So as someone's talking, I will make little E flags. So that's a quote from David Butler, who's a fantastic pain scientist. So an E flag is an education flag. So while you're talking, I'm not going to interrupt, but Nathan talked about he's worried that it hurts. Okay, so that's an E flag. That's an opportunity for me to do some education. He talked about he's worried about the imaging and how it looks. Okay. So as you're talking, I'm just making all these little notes that I'm going to circle back to, because if I don't take the time to address inaccurate language or fear of movement or fear of pain, if I don't take the time, I could write the world's best exercise program and you're not on board. And I don't blame you, because inherently your experience is to trust yourself. And so while I can build therapeutic alliance, I'm better off spending my time building my therapeutic alliance in teaching you how to trust your body, when to listen. So your body's going to give you great information. But what I want to do is say to you, Nathan, your tendon is a bit sneaky. And when we're doing some exercise in the gym, you might feel it a little bit. I want to reassure you that that's okay. I want you to tell me how your tendon felt the next day. So I'm going to give you permission to ignore it at some points, but I'm going to ask you to listen to it at some points. And so it's helping people filter the noise. But I think if we don't take the time in framing our treatment and giving that much time to what you've said, the words you've used, and your understanding, then that will affect adherence. I'm always interested if I see someone for a second opinion, if they haven't done their exercises, because I think that is unbelievably rich information. If they haven't done it, why? Did they not understand the value? Did it make them worse? Because actually not everything in the posterior ankle is Achilles tendinopathy, and some conditions are worse with a calf rise. So if you come back and say to me, I tried, Ebonie, they gave me calf raises, they absolutely made my pain worse, that is clinically So valuable to know. So as soon as someone isn't adherent, fantastic. Let's chase that. But when you're structuring your time, don't underestimate the value of listening to the person. Don't underestimate the value of meeting them at their story. That's another Dave Butler quote, and making sure that you're, taking the time to validate them and empower them. And then your exercise is a mainstay for tendinopathy. And the last thing would be things like manual therapy. I'm not saying manual therapy doesn't have a value, particularly if it's allowing someone to do their exercises. But if you come straight in and I get you on the bed and I rub your calf and then quickly check your exercises at the end, then what I'm telling you is that I don't value the exercises. So even if you don't say it out loud, that's what you're going to hear as well, that I don't value it, which means you think, oh, how important are they? Like, she barely looked at them. So making sure our conscious and our unconscious messaging is really clear.
Yeah, I see a lot of that where people are struggling with the execution because they didn't have time in the session. And they don't have the experience with exercise. So it's very hard for them to figure out how to even execute it correctly, even if they want. The other thing I want to just enlarge on there slightly was, because this is a conversation that happens even outside of physiotherapy, where for lack of a better word, the holding environment. And I wanted to circle back to your experience with athletes, because with athletes, I deal with, there's this thing with coaching where, it's not just about the information. Coaches have very different styles, and the relationship between the coach and the coachee, really makes a big difference in terms of what gets absorbed and what gets done. It's not just, and I've talked about this with a lot of our high level performers and stuff, but I've experienced it myself when I'm being coached by high level folks. Some people are very intellectual and cerebral, and they'll explain all the whys and the wherefores. Some people are, let's just get down to business and do it. Like, people have different personalities and they come together in different ways, but that actually affects the outcome of the, either, if they're not injured, just high performance or just regular performance or achieving the skill, and it can affect other things. So it's like, yeah, it's great to have all the correct information. And if you were computers and AI, well, you just hook them up and download it and it'll all take care of itself and run the program. People don't operate like that. People are worried. People have to get to know other people. People have feelings about people's personalities. And so this environment in which the either, physical therapist or coach or, whatever, and the athlete, that actually is a part of the result you get. And I'm wondering if you can talk, because yes, it can be education, right? It can be education flags. It can be telling people the right things. It can be taking time. It can be listening. That's all true. But there's this other X factor of who are these two humans and how do they gel when they're trying to solve a problem together? Can you say something about that? Or have you seen that in any of the ballet companies, the Olympics or things like that? Can you talk a little bit about that? Because I have talked about that with a lot of the other high level folks, and I'm just curious about your thoughts.
Yeah, I love that. And you're right. It's the X factor that people have tried to give different names to, like therapeutic alliance, but there probably isn't one term that captures it all, right? It probably is the X factor. And in a session when you've nailed it. And I think you also know when you haven't. So right. It's palpable. So, I think allowing people to talk would be the first thing. So there's some research that shows that physios interrupt within seconds of people starting. So we'll ask a question and then we'll interrupt. And I often have to stop myself. I might want to clarify a point, but I'll just make a little asterisk. I need to come back to it. So I'm just going to let that person talk. And I think as a junior physio, you interrupt even more because you've got your list of questions that you don't want to forget. But I think as you become more experienced, you're more comfortable with it being a conversation and allowing them to drive the direction that it takes. And those extra questions come more naturally. So I think, people having lots of conversations with, family and friends and just getting more experience with the listening, because you also pick up on specific terms. You'll pick up on their social connections, so much of how they describe their story. You'll get just so much rich information that you can make a note of and really come back to help support them. But I think you've nailed it about the person being at the core. So Lorimer Moseley talks about the 4 questions of self-efficacy. And this is how I like to frame, working with someone. Someone wants to know what's wrong with them. What can you do about it? What can I do about it? And how long will it take? So I think if you think as you're working through with someone, give them a really clear idea of what you think is going on in the picture as best you can, including any grey areas. That's okay. Humans are messy. That's fine. I'm really honest about that. I'm really honest if I want different opinions. I think that's good. It actually, we don't have all the answers.
Yeah.
What can you do? What can you do about it? Gives me an opportunity to say, okay, Nathan, we used to think that tendons were inflamed. We used to call it tendonitis. I'm going to use this as a teaching moment to explain to you what tendinopathy is, explain why exercise is important. So this is where I'll meet you at your story. So what we have is capacity and load. And your capacity only ever just exceeds the loads you put on your musculoskeletal tissue, so tendon, muscle, bone. And what happened, Nathan, is you were training for something and increasing your load, and you did a really big session, so you're overloaded. So you had pain. So what you did is you had a couple of weeks off, and that's, what you thought you needed to do. But what happens to your capacity with a couple of weeks off is it drops. And then you went back to training, not thinking that you were overloading, but do you see how you're overloading to your new relative capacity? But then you think, oh, maybe I didn't rest long enough. So you have another couple of weeks off and your capacity goes down. So I'll actually go through your story with you to say, here's how you ended up, you tried this intervention, you had some time off, or, and I'll actually meet you at your story with your story. And then that leads into what can you do about it? What you can do about it is slow progressive load, because that builds your capacity. So that reinforces that the work to be done is outside of the physiotherapy room. I'm going to help you and I'm going to support you. But actually, if you aren't on board, this won't go away. There's actually no magic bullet for tendons. And I'm really honest with people. If there was, I'd tell you. Right. There's no reason I wouldn't tell you. What can I do about it? I'm here to support you. I'm going to teach you when to listen to it. I'm going to teach you what sort of capacity we're looking for. I'm going to help you get back to what your goals are. So what are your goals? And then the fourth one, how long will it take? Again, I'm really honest with people. If their calf capacity is, 6 and they want to run an ultra marathon, and I've had that, we're looking at months. Because we know that improving muscle strength, for example, in that athlete is going to take 12 weeks. And then we need to reload some spring, and then we need to build our volume. So you can give people an idea of time based on where they're currently at and where they want to go and how far away those points are, give or take. But you can give people a little bit of an idea as to how long it will take. The tough sell is that these aren't fast and people will need to do the work.
Yeah, it's a journey, and it's a journey. And I wanted to ask you about that because I think, people can get confused. Like, what do I do? When do I do it? Like, how do I? And wait, now I have to go off by myself. And and so this really is a journey. And you can see where people would be a little hesitant to understand all the ins and outs of that journey. And then also, like, can I even make it over the mountain? And then I wanted to ask, a lot of people don't. That's not their thing. I sometimes think, like, if they could make a perfect pill that would do it instantly, like, if you could take like myostatin and, inhibitor and mix it up with Wegovy and like make this perfect pill that would keep you lean and also make you immediately muscular and like do it all for you. A lot of people would want that pill. And so I'm just wondering, like, when you work with athletes and you talked in the beginning, maybe we close where we started. You said one of the inspiring things about them is that they're so motivated that they really, do you think it's because they're, just more gifted, so they are more inclined to do it, or they like it more? Or is there something about the athletes and the artists that makes them want to stay with that long process that maybe our day-to-day folks might struggle with more? Or is it just, what is your experience with that? Because that is ultimately one of the big questions. How do people make that journey? Do people want to make that journey? And what is it that makes it possible for people to make that journey? Because it is a journey of figuring out, of trial and error, of being patient. And that's so hard for humans, myself included. Patience is a challenging thing. So what do you see with athletes? Does that teach us anything about this longer journey? That's my last question for you.
Yeah, there's no doubt that they have a unique ability to push themselves, and, motivation to exercise is rarely a barrier the way it can be in, general public. But also there are a lot of people in the community that possess those same attributes too. And sometimes their motivation is what tendinopathy is taken away from them. So they may not have been a lifelong exerciser, but now they can't even, walk their dog around the block. And so sometimes that can be, the catalyst for them getting into exercise and actually adopting a more healthy lifestyle. And so I think people's motivations can definitely be different, but dancers and athletes, you rarely, often you're holding them back. You're not really needing to push them in the same way. But I think finding out people's why and spending time on that is really important. And because tendinopathy can be, debilitating in terms of people's ability just to live their life. Sometimes by the time they see you, they're very amenable to
trying.
To trying. Absolutely.
Yeah. Well, thank you so very much. I really appreciate